Hi, welcome to the NYU Child Study Center's webinar series. Today, Dr. Rahil Jummani, will talk about fact and fiction, identifying and successfully treating ADHD. I'll start by telling you just a little bit about myself. I'm a practicing child and adolescent psychiatrist, and I've had the pleasure of practicing at the NYU Langone Medical Center for over a decade. I am the medical director of the Long Island campus of the NYU Child Study Center, and I also have a bit of an administrative hat in that I am the program director for our child and adolescent psychiatry training program, and so oversee the training of 20 extraordinary fellows each year. So without further ado, let's talk about ADHD, attention deficit hyperactivity disorder. I'd like to get started by posing some questions. And so the question I'd like to start with is, which one of these statements is true? The first statement is ADHD is a made-up disease that has no scientific basis. The second statement, there are no diagnostic guidelines for ADHD. Even if ADHD exists, it does not need to be treated. There are no effective treatments for ADHD. And the fifth and final statement that I have here is the treatments for ADHD cause more harm than good. So as you're considering those, let me tell you that none of those statements is in fact true. But we'll look at the details of each of those statements and talk about why each of those statements is in fact fiction and not fact. So the first statement I read to you was ADHD is a made-up disease that has no scientific basis. So this is absolutely fiction. Symptoms of ADHD have been recognized and described by physicians dating back some 300 years to the 1700s. And ADHD has been recognized as a long-term pattern of behaviors present in multiple settings that results in social, educational, and occupational difficulties. Now, as we talk more about this disorder, as we talk more about attention deficit hyperactivity disorder, or as I will refer to it from here on out, ADHD, you may recognize some of these symptoms and say, I recognize some of these symptoms in myself. I recognize some of these symptoms in friends and loved ones, and they don't have ADHD, and they're not in treatment, and their life is fine. And so one of the things to keep in mind is that we're talking about degrees of severity here. So for example, other than ADHD, if you look at other medical entities, for example, if you look at blood pressure, all of us have ranges of blood pressure, and there are times when each of us has an elevation in blood pressure, and that doesn't necessarily mean that we have a problem with blood pressure, or as doctors call it, hypertension. However, there are individuals whose blood pressure is often elevated, and so they fall into the clinically concerning range and are diagnosed with a problem with blood pressure. And the same is true as you think about the signs and symptoms of ADHD. They exist on a continuum, and each of us likely has some of the symptoms, or can recognize aspects of symptoms that may be true for ourselves or others that we know without having the full disorder. And then there are others who have significant symptoms that are clearly impairing, either academically, socially, and into adulthood occupationally. And these are the individuals that we are discussing, individuals who have enough symptoms to cause significant functional impairment and really devastate their lives. Now, that being said, to address this issue about ADHD being a made-up disease, not only are the symptoms of this disorder recognized, and not only have they been notable for hundreds of years, but we now are in an era when we are able to look at the brain and examine it, and we recognize that there are clear chemical differences in the brains of individuals with ADHD. In fact, important neurotransmitters in our brain, neurotransmitters such as dopamine and norepinephrine, seem to be deficient in individuals with attention deficit hyperactivity disorder. In addition, we now have sophisticated neuroimaging techniques such as positron emission tomography, or PET scanning as it's known, that demonstrate that metabolism is different in parts of the brains of individuals with ADHD. In fact, the frontal lobes, the frontal part of the brain, that actually makes a lot of sense because things that are compromised in individuals with ADHD, the ability to control impulses, the ability to plan and organize, those activities we believe do in fact occur in the frontal lobes. And so for there to be a difference in the frontal lobes of individuals with ADHD is clearly correlated with rigorous scientific finding that this is in fact the disorder that involves brain structure and something that clearly causes significant disruption, dysfunction, and deserves to be treated. In addition to the neuroimaging studies, the neurochemical findings, we also have findings that indicate that there is a strong family or genetic component to disorder. So in fact, if you are a relative of an individual with diagnosed ADHD, you are at an increased risk of having the condition yourself. And if you look at siblings of individuals with ADHD, if you look at identical twins, if you look at twins that are not identical, and you look at other siblings in the family, depending on how much genetic material those individuals share, increases the likelihood that they in fact will have ADHD symptoms or the full syndrome themselves. And so identical twins are in fact at the highest risk of having ADHD diagnosed when their twin has the diagnosis. So we have genetic as well as neurochemical and imaging sort of evidence to suggest that this is in fact a true disorder. Now we believe that ADHD affects about 5% of children. There is a range. You may see numbers as low as 2% or rates as high as 20%, but a conservative estimate is that about 5% of children do in fact warrant a diagnosis of attention deficit hyperactivity disorder. There seems to be a gender variance here as well. Boys seem to be at least twice as likely to be affected. And so at minimum, we believe that there is a 2-to-1 ratio, and it may be more than that. It's also possible that girls with ADHD are missed. And I'll explain in a second why that may be. Core symptoms of the disorder, as the name alludes, include inattention, and we'll talk more about some specifics about the inattention that we see in ADHD. Other core symptoms include impulsivity and hyperactivity. Boys that are hyper and impulsive, and they tend to be more hyper and impulsive than girls, are more likely to be diagnosed and more likely to be diagnosed at an earlier age. And so boys and girls who are more inattentive, who may be quietly unfocused and not performing academically, but are not necessarily behaviorally challenging, may get missed. And girls tend to be more inattentive than hyper and impulsive. So that may also account for some of the variance that we see in terms of gender. So the 2-to-1 or even a different ratio than that in terms of boys versus girls may be a little artificial, and it may be inflated because ADHD likely looks a little bit different depending on whether you're a boy or a girl. So that's something to take note of as well. So now we've talked a little bit about the biological basis for ADHD. Clearly there are neurochemical differences. We see differences on imaging, and we see that there are familial and genetic patterns that also indicate that this is a true disorder that is clearly impairing. So the next statement that I read at the start of our webinar was that there are no diagnostic guidelines for ADHD, and that is also fiction. Consensus diagnostic criteria are actually found in 2 places: the International Classification of Diseases, 10th revision, or the ICD-10, as it's known, and also the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or the DSM-5. We in the US like to do things our own way, and while the rest of the world tends to stick to the ICD-10, we tend to use both the ICD-10 and the DSM-5, and many of us use the DSM-5 more. Regardless, both of these classification systems are well recognized and accepted, and are ways to look at ADHD that are universal. So let's talk a little bit more about what those symptoms are momentarily. So the diagnosis, how does one make a diagnosis of ADHD? It really depends on thorough interviewing of parents, a child, the child that's affected by the disorder, and also collateral sources of information. So to establish a diagnosis, a physician, a clinician must be convinced of the presence of persistent impairing symptoms of either hyperactivity, impulsivity, or inattention. And it could be all of the above, but it isn't required. There are different subtypes of ADHD. One subtype is primarily based on a child being hyperactive and impulsive, another on a child being primarily inattentive, and then the combined type means the child is experiencing symptoms of all of the above. And this impairment due to these symptoms must be present in at least two different settings, home and school, home and camp. And it's critical to get information from individuals in the child's life. Often a child isn't able to tell us what they're experiencing, but others who are with them can. So teachers are invaluable in telling us how the child's symptoms are manifesting in school and impacting academic functioning. Thorough history is critical. And I tell my patients that I don't have a lab test or an imaging test that I can do that is diagnostic. It doesn't exist for this disorder. So the more comprehensive, thorough, thoughtful, careful I am in obtaining information, the better I am as a diagnostician and can more accurately make the diagnosis. Now, there are things that I can also elicit that are helpful. I can obtain questionnaires from teachers that gives me additional information, and I can track that over time to see how my treatment is working. I can do some tests in the office. I can do something called a continuous performance test. One example of that is a child is seated at a computer, and for several minutes they are asked to click on a mouse or the space bar every time a letter pops up on the screen, unless it's the letter X. Now, this is called a visual continuous performance test, and we're looking for two things. We're looking to see if the child is being inattentive, so if the child is spacing out and not hitting the mouse when they're supposed to, or if they're being impulsive. So even if the letter X pops up, they're still clicking on the mouse. So that gives us some information, but a test like this by itself does not the diagnosis make. So the history piece and the conversation with teachers and parents is critical. And again, there's no specific diagnostic tool other than a clinician doing a thorough interview with families and soliciting information about the symptoms. In terms of the symptoms of hyperactivity, this typically involves a child who is fidgety, unable to stay seated. They are often described as running around, jumping about, climbing furniture, unable to sit still, restless. They tend to have difficulty engaging in leisure activities quietly. They're described often as being on the go, driven by a motor, talking excessively. In terms of impulsivity, they blurt out answers before questions are even completed in the classroom. It can be highly disruptive to the functioning of a class. They have a lot of difficulty waiting their turn. They simply can't wait. They tend to butt into conversations, they interrupt and intrude on others. And you can see how this impulsivity and hyperactivity would not only hinder academic performance, but clearly have social consequences that are negative as well. The other important piece of the diagnosis in terms of symptoms is the area of inattention. You will find that individuals with ADHD struggle to pay attention to details, and they make careless mistakes in their work. They're often avoidant of tasks that require sustained attention. So homework is really a chore for them, and they will put it off and they will procrastinate. Projects can be very difficult. And once they are actually engaged in an activity that requires sustained attention, it can be extremely challenging for them as well. They seem not to listen, and this is not intentional. They are, again, not focused and not optimally present when they need to be. They experience a lot of difficulty organizing tasks. So again, long-term tasks that require multiple steps, prioritizing tasks, managing time. These are all things that are extremely challenging. And the individuals are easily distracted. I actually witnessed one of my trainees do an interview earlier this morning with an 8-year-old who has been diagnosed with ADHD, and it was very clear that throughout the interview, this child was distracted and not able to focus, even in a one-to-one setting where the psychiatrist was giving the child their full attention. Often children with ADHD will fail to finish tasks, and adults will take on projects that they want to engage in, including projects that they're happy to engage in and be unable to complete them. And you can imagine that in the workplace, this can be quite a challenge as well for adults. Individuals with ADHD will lose belongings often and easily, and they tend to be forgetful. So clearly, a well-established entity with significant impairment. And so the next statement, as you can gather from what I've discussed so far, is also fiction. Even if ADHD exists, it does not need to be treated. Now, I wish this were true. There are individuals, like I said, this is a disorder where you will likely see some individuals who don't really have the full diagnosis, who may have some of its symptoms, and you will have some individuals who do have the diagnosis that have a mild ADHD. But unfortunately, many have significant impairment from disorder. Untreated ADHD has numerous consequences and can lead to low self-esteem, depression, substance use, academic and occupational challenges, as well as social struggles are notable. Most children with ADHD have some social difficulties. Socially struggling children with ADHD experience more problems with behavior in school, as well as with peers and family members. And so this leads to a lot of problems in not only school, but home life as well. ADHD rarely is found in isolation. It often involves other issues as well, including learning disabilities, motoric challenges. Individuals with ADHD are also at increased risk for anxiety, tics, OCD, and substance use. Approximately 50% of children with ADHD go on to be adults with ADHD. So the earlier it's identified, the better the child can be treated and the brighter their future. Adults who remain untreated, when you compare them to the general population, are more likely to experience anxiety disorders, mood disorders, and substance use disorders, are more than twice as likely to have been arrested, are 47% more likely to have received one or more speeding tickets in the previous 12-month period, are 78% more likely to be addicted to tobacco, are twice as likely to have been divorced, and are 78% more likely to be currently unemployed. So clearly there are major sequelae to this disorder, and untreated ADHD can have a concerning prognosis. The next statement, there are no effective treatments for ADHD, is also fiction. Medication to treat ADHD was actually accidentally discovered almost 100 years ago in 1937 by Dr. Charles Bradley. And in fact, he was using central stimulants to treat headache, and what he recognized is that the children he was treating responded wonderfully to this intervention with decreased hyperactivity, impulsivity, and improved focus and attention. Since then, more research has been published on ADHD and its treatment than any other childhood disorder. There have been multiple double-blind, placebo-controlled studies, which are the scientific gold standard for research, which means that the researchers that have done these studies in terms of ADHD treatment were unaware of whether the patient was receiving a placebo treatment or actual medication. The patient was unaware as well. And these studies have clearly shown a significant difference between the ADHD medications that we use and treatments that do not work for ADHD. Medications have been found to be immensely effective and reduce impulsivity, hyperactivity, and inattention. They improve academic performance and peer interactions. We know the side effects well, given the over 50 years experience with these drugs. Methylphenidate, which is one of the key treatments for ADHD, has been marketed since the 1960s. In terms of medications, we have non-stimulants and stimulant treatments. The stimulants are by far the most effective treatment and consist of two families. The methylphenidate family, you've probably heard of medications like Ritalin, Ritalin LA, Metadate CD, Concerta, Daytrana, Quilament XR, and then the amphetamines. And they include Adderall, Adderall XR, Dexedrine, Vyvanse. These two families are really the cornerstone of ADHD treatment and work quite effectively. And we know the side effects well. Again, given the over 50 years of experience and the significant research that's been done on these treatments. Now, there are non-stimulants available. They tend to be less potent, but they are a good choice, especially for individuals who aren't able to be treated with a stimulant for one reason or another. These treatments include the alpha agonists. Again, you may have heard of some of these, Catapres and Capve, Xanax and Intuniv. Strattera is also a non-stimulant that is fairly well used. There's an antidepressant by the name of Wellbutrin that is also a medication that we use to treat ADHD, and a medication for narcolepsy, Provigil, that is also effective for the treatment of ADHD. Finally, omega-3 fatty acids, fish oil, have been shown to be helpful. There's actually been several studies, and when you put all the data together, the effect seems to be mild, but there does seem to be a positive effect. So sometimes in a child with mild ADHD, this may actually be the way to start. Now again, thinking about most kids who require treatment for ADHD, stimulants are the choice medication because they have the most impact in terms of improving attention and focus and decreasing hyperactivity and impulsivity. And this last statement, the treatments for ADHD cause more harm than good, is also fiction because the side effects are generally mild and tolerable. Common side effects include headache, stomachache, nausea, decreased appetite, insomnia, and mild increases in heart rate and blood pressure. And some of these symptoms actually dissipate once the child has been on treatment. So again, they're generally mild and quite tolerable. You can see an effect on growth if the child has significant appetite suppression and does not have any drug holidays. So we often actually encourage families, when it's possible, to give them no stimulant on weekends. Sometimes children are able to not be on their stimulant medication for the summer break. And these are things that help them to stay on their growth curve and not have a significant impact there. Another piece is that stimulants vary in terms of their longevity. There are some short-acting stimulants. There are also longer-acting stimulants. You can get behavioral rebound at the end of the day when stimulants are wearing off. So some kids may appear more hyper and also irritable at the end of the day. Again, that's a side effect that may improve with increased use and also needs to be monitored. And there are strategies that we can employ to mitigate that. Tics and anxiety can be exacerbated. Something to keep to monitor. Something to also know that tic disorders seem to be related to ADHD, and so children may be prone to tics independent of the ADHD treatment. And in fact, some children actually have an improvement in their tics when they're treated for ADHD. So it's not this clear relationship of stimulants causing tics. In fact, we don't believe they may bring them to the surface and exacerbate someone who's prone to having tics already. The last thing I'd like to say about treatment is that medications are not the only treatment. Non-pharmacologic interventions are also critical. So when I treat patients, it's not only about using medication to mitigate symptoms, but it's also about holistically treating the child in their context of their family and their academic goals. So, I strongly recommend support groups, including children and adults with attention deficit hyperactivity disorder. CHAD, it's a well-known group that provides a lot of useful services for children and families struggling with ADHD. I recommend social skills groups for children with ADHD who have significant social struggles. Behavior modification strategies at home and in school are extremely helpful and necessary for some children with ADHD. Organizational skills training is something that we offer at the Child Study Center that helps many individuals who struggle with this aspect of ADHD. And there are many interventions that are focused on school to help the child's performance, their behavior in the classroom, their peer relationships. Clearly, it's important to collaborate and partner with teachers to provide appropriate accommodations and modifications, as well as just understanding of the child's disorder and their struggles. Evaluation and treatment of coexisting learning disorders or additional psychiatric conditions is also essential. As I mentioned earlier, anxiety, depression, tics, substance are all things to be on the lookout for and to be vigilant about and to aggressively treat if necessary. Now, we're open for questions. I believe we have some questions already. So the first question I have here is, I have a teenage son and I'm scared about substance abuse as he is extremely impulsive and entering high school. Are there any evidence-based interventions to prevent substance abuse in teens with ADHD? So that's a fantastic question. There's a lot in the literature. There's been research on ADHD, and the consensus at this point is that the earlier ADHD is treated, the more you mitigate the risk of substance use and abuse. It's important for all families, whether you have a teenager with or without ADHD, to have conversations about choices, about substances and pressure and the need to use. In a child with ADHD, it's important to make sure that the child is optimally treated, that they have the support and the resources that they need. If their ADHD symptoms are significant, clearly medication intervention is maybe necessary. Also, appropriate interventions in school, both academically and socially, are critical. So if the child has a healthy self-esteem, feels confident, is thriving, doing well with friends academically and in the home, they are less likely going to go into this divergent pathway of substance use. But treating the underlying disorder and having conversations with your child about the perils of use and the pressure to use are critical. So the next question we have is, what is your understanding of sluggish cognitive tempo? Is there a way to test for this? So this is sort of a description of some children with ADHD that has been used in the past. We tend not to use this language so much, and it suggests that the child may, in fact, have delayed or slowed processing. And there are ways to really test for this. So you can request psychoeducational testing through your school district, where they can actually do cognitive testing, looking at your child's memory, their learning skills and strategies, whether they're visual or auditory learners, and how they process information and how rapidly they process information. And that can sort of look at sort of this cognitive tempo question. So this issue of, does my child have a sluggish cognitive tempo? So psychoeducational testing through the school district can certainly be done. And then if you need more testing, more nuanced testing, psychoeducational or neuropsychological testing can be done at a center like the NYU Child Study Center, where we can really work with families, thoroughly look at testing results and make recommendations for the child's academic needs, and make sure that the school implements appropriate accommodations, modifications, and services that the child might need. This will be our last question. I have someone who is writing, I have a 3-year-old that I suspect may have ADHD. Is he too young to be diagnosed? What steps should I take? This is a great question. 3 is probably the cutoff. Prior to 3, it would be extremely challenging. But yes, you can certainly go to a center, especially one that specializes in the diagnosis of ADHD, and talk about your child, their presentation, what you're seeing. And you may be told, this is a typical 3-year-old child that we see in our office and that you are describing to us. Or you may have a clinician say to you, based on everything you're saying and what we're seeing in the office, it does sound like your child has an increased risk for developing ADHD or clearly demonstrates signs and symptoms of the disorder currently. That being said, there have been studies looking at young children prior to the age of 5. What we find is that medication intervention is not the first choice. In fact, behavioral interventions are much more likely to be successful in the preschool age range. And so even if a 3-year-old merits the diagnosis and someone is able to make that diagnosis, the first interventions would be behavioral in nature. If the disorder seems to be quite severe, perhaps medication may need to be considered, but it would not be the starting place and certainly not the first choice. Thank you for joining us on behalf of the Child Study Center. I thank you, and once you leave the webinar, you will receive a survey. We would appreciate if you would complete it. You will also receive a follow-up email within 24 to 48 hours with a link to a recording of today's webinar. We hope you can join us for our next webinar, Tourette Syndrome in the Classroom, Collaboration and Accommodations for a Successful School Year. That's on Tuesday, September 20th at 1 p.m. Thanks again.